It's really a pleasure to be here today to share one of my research projects with you, which focused on exploring the impact of COVID-19 on immigrants and refugees living with cancer or mental health and addiction. Now, because I can't share all those interesting results with you, I would encourage you highly to visit our website where you can see more information about this project and its findings. And I will be always available in case you have any question regarding some of the findings that we have. So before we dive into explaining why, what was the result of our study, I think it would be a good time for us to provide some background in terms of why we focus on this particular research question and what we knew at the time when we started the study. So as everyone knows, immigrants make up about half of the COVID-19 cases at the time during the pandemic, although they only contribute to 25% of the population, so a very high number. The racialized immigrants have been affected quite hardly by the COVID-19. The highest rate of COVID-19 was among people who identified as South Asian or Indo-Caribbean, Black, Southeast Asian, Arab, Middle Eastern or West Asian. This wasn't really a surprise to anyone because this really reflected a long-lasting structural inequities that existed in Canada and also other parts of the world. As you all know, many immigrants work in high-risk, low-paying, precarious jobs, often in essential services with limited workplace protections. They are also more likely to live in poverty, in overcrowded housing, and face barriers to accessing healthcare. These social and economic challenges contributed to higher exposure to the virus. But what happens when socially disadvantaged people also suffer from a serious or a chronic health condition? In Ontario, cancer and mental health and addiction are among the leading causes of mortality and morbidity. Cancer and its treatment weakens the immune system, making individuals more prone to infections like COVID-19. Similarly, mental health and addiction disorders can increase vulnerability by limiting access to care, disrupting treatment continuity, and weakening coping mechanisms. But here's the key point. No one really knew at the time what the impact of COVID-19 was for people who faced both social and clinical disadvantages. So our study aimed to address this knowledge gap. So let me walk you through our study design, which combined the mixed methods across two phases. Our work, as I mentioned earlier, was to assess the impact of COVID-19 on immigrants and refugees living with cancer and mental health and addiction, and identify community-driven solutions to support their health during the pandemic and in future crises. In phase one of our study, we conducted a population-based retrospective cohort study using linked administrative, social, and health databases available at ICES. The study covered the period from March 31st, 2020 to December 31st, 2021. We examined 5 key health outcomes: COVID-19 infection rates, hospitalization, ICU admissions, mortality, and vaccination uptake. We compared these outcomes for immigrants and refugees with cancer or mental health and addiction to non-immigrants with or without, as well as immigrants without these conditions. In phase 2 of our study, we hosted 2 virtual half-day think tank sessions, one on cancer and one on mental health and addiction. Participants included affected community members, service providers, and policymakers. So these flowcharts, which I doubt you can see it very clear from where you are sitting, really try to show how we selected participants for each of the 2 study cohorts. Each cohort included about 10.3 million people living in Ontario. So let's take a quick look at the characteristics of the immigrant population in our study. On average, immigrants were slightly younger and had been in Canada for about 17 years. 16% were refugees or protected persons. 34% of immigrants lived in Toronto Central. Largest immigrant groups were from East Asia and the Pacific, followed by South Asia. Compared to non-immigrants, more immigrants live in areas with lowest household income, highest residential instability, greatest material deprivation, and highest ethnic diversity. Fewer immigrants had a regular primary care provider, pointing to gaps in access to consistent care. Next slide, please. Now let's begin with those in our study who were living with cancer, active cancer. 0.7% of immigrants were living with active cancer, compared to 1.2% of non-immigrants. Immigrants with active cancer tended to be younger, more likely to be women, and more likely to reside in socially and economically disadvantaged areas. Now let's turn to individuals living with mental health and addiction disorders. 8.9% of immigrants were living with mental health and addiction, compared to 13.3% of non-immigrants. Although mental health and addiction conditions were less frequent among immigrants, those who were affected were less likely to be young adults or seniors. They were also more likely to live in low-income and ethnically diverse neighborhoods. The types of cancer were similar between immigrants and non-immigrants, with breast cancer being the most common, taking up over 25% of cases among immigrants. About 15% of immigrants with cancer also lived with a mental health and addiction disorder, mostly anxiety, followed by mood disorders. Although only 1.2% of immigrants with cancer lacked a primary care provider, this still matters, since primary care is crucial for coordinating treatment and ensuring continuity of care. Among immigrants with mental health and addiction, anxiety was more common than in non-immigrants, suggesting higher day-to-day psychological distress. Also, 1.1% of immigrants with mental health and addiction also had cancer, indicating the overlap of mental and physical health needs. So this slide really shows the prevalence of COVID-19 diagnosis. The red bars represent immigrants and the blue bars represent non-immigrants. In both cancer and mental health contexts, immigrants had significantly higher infection rates than their non-immigrant counterparts. Among immigrants with active cancer, the infection rate was more than twice as high as for non-immigrants with cancer, 7.4% versus 3.2%, a significant disparity. Similarly, among those with mental health and addiction, immigrants had the highest rate at 9.2% compared to 5.2% among non-immigrants with mental health and addiction. These findings highlight how clinical conditions intersect with social disadvantages to amplify infection risk. This slide shows COVID-19 vaccine uptake across 4 groups. The red and purple bars are immigrants, and the yellow and blue bars are non-immigrants. What stands out is that immigrants, whether they had cancer or mental health and addiction, were consistently less likely to be vaccinated than non-immigrants. We also saw that vaccine uptake dropped with each additional dose, especially among immigrants. These patterns suggest ongoing barriers to access or trust and point to the need for more equitable and targeted vaccination efforts. So we used logistic regression, which I'm not going to be dwelling on it a lot, but it's just a method that estimates the odds of specific outcomes, such as contracting COVID-19 or being hospitalized, while controlling for other factors that might influence those outcomes. So our logistic regression analysis showed that immigrants with cancer were among the most affected. They were 66% more likely to be diagnosed with COVID-19, 3.3 times more likely to be hospitalized, 3 times more likely to be admitted to ICU, 4.2 times more likely to die from COVID-19, and about 50% less likely to be vaccinated. Similarly, immigrants with mental health and addiction faced elevated risk across most outcomes. These patterns highlight how immigration status combined with complex health needs significantly increased vulnerability during the pandemic. So in our phase 2, our think tank sessions generated equity-focused, community-driven solutions. From the cancer think tank, key recommendations included engaging internationally educated health professionals as community health ambassadors, given their clinical expertise, language skills, cultural insight, and community trust. Second, connecting newcomers to health and social services early on during their settlement process, starting as early as when they go for a medical examination for immigration purposes. Third, expanding the reach of community health centers. They are often the only access point for those without a family doctor. And the fourth recommendation from this group was creating a centralized provincial health portal with multilingual, culturally safe information, especially valuable when in-person services are limited, which what happened during the COVID-19. From our mental health think tank, we heard a strong call for cross-sectoral collaboration to address root causes of mental distress among newcomers, co-designing programs with communities to ensure they are grounded in lived experiences and cultural values, mandating cultural competency training for frontline workers with a focus on anti-racist, trauma-informed care, and finally, improving digital and health literacy as many newcomers struggle to access virtual care or navigate health information. This concludes my presentation.